So I will call to order now the meeting of the Board of Directors for Watsonville Community Hospital for Wednesday, August 26th, 2026. Rosie, when you have an opportunity, please give us a roll call.
Yeah, Director Bali? Here. Director Friel? Here. Director Gallagher?
Here.
Chair Nunez?
Here.
And Director Pimentel out.
Okay, we have nothing to report out of tonight's closed session, so I'll now move on to agenda modifications for consideration from staff. Is there anything on this agenda that we'd like to modify? Okay. Seeing none, I'll move us on to public comment on matters not on tonight's agenda. Rosie, I'll first go out to the public online. If you do have any attendees, anyone online wishing to speak on items not on tonight's agenda?
No hands online.
Okay, and move in person. Anyone in person wish to speak on any items? Okay, seeing none, I'll close down the public comment. I'll bring it back to any comments from our board members tonight. Comments from the board? Okay, I'll close down the public comment, or excuse me, the comments from our board members and move us on to the consent calendar. Rosie, if you can, we have 3 consent calendar items tonight. If you could read them off for us.
Yes, the minute approval of July 29th, 2026, the policies and policies summary approval of August 2026, and the Watsonville Community Hospital quality report from August 2026.
Okay, do we have any questions for staff on this before I go into public comment on the 3 items of the consent calendar? Okay, seeing none, then I will open up to public comment on the consent calendar. Anyone online wishing to speak on either of these items?
No hands online.
Seeing none, anyone in person? Okay, I'll close down the public comment and I will bring it back to the board for any closing comments and an appropriate motion on the consent agenda.
Moved. To approve.
Okay, can I get a second?
Second. Okay, Directors Friel and Gallagher, thank you. I'll take roll on this item. Director Bali? Yes. Director Friel? Yes. Director Gallagher?
Yes.
And Chair Nunez?
Yes.
With Director Pimentel absent.
Okay, that'll bring us to item number 4. This is the Medical Executive Committee's report approval for August 2026. As a reminder, this was a report that we received in closed session. And I'll first, before we go to public comment, I'll first ask the board if there's any questions for this item. Seeing no questions, I'll move us out to public comment. Anyone online wishing to speak on item number 4?
No hands online.
Okay, anyone in person? Okay, seeing none, I'll close down the public comment on item number 4 and bring it back to the board for an appropriate motion. Approve. Thank you.
Second.
Thank
Director
you.
Gallagher and Friel?
Yes.
Thank you. I'll take roll on this item. Director Bali? Yes. Director Friel? Yes. Director Gallagher?
Yeah.
Chair Nunez?
Yes.
With Director Pimentel absent.
Okay, we'll move on to item number 5. This is the leadership report from our interim CEO, Tim Moran. Tim.
Thank you. Before I start my report, I do want to digress for a moment and thank the board for your advocacy on behalf of the hospital. I have a letter that was sent to the Honorable Robert Rivas, the Honorable Jesse Gabriel, and the Honorable David Kanjipa. I may be mispronouncing that name. And it's expressing the county's concern on behalf of a number of hospitals that are safety net hospitals, which of course we are. And I know your engagements with the board have been instrumental in helping us, and I feel it should be acknowledged. And if you could note that for the record, I would appreciate it, Rosie.
Yes.
Okay.
Thank you from the.
For their advocacy on behalf of not only this hospital, but the whole community. We're in the middle of worrying about what's going to happen with the impacts of HR 1. Will the county sales tax be approved? You know, that might help safety net facilities like ours. So, and there are a lot of unknowns. Co-op 9 is in play, but we don't know yet about Co-op 10. So I think this type of advocacy is very important and it's much appreciated. On a less happy note, They are at least taking my calls now. Licensing has not yet given us the green light, but I did get 2 calls from them. One of their people is trying to get us some answers, and if we do get an answer this week, we have a go ahead, then I'll certainly let you know. I have put in place a sales strategy with Francis's help, so we can hit the ground running to get to the public, get to the referring physicians about the advanced technology that we were able to do as a result of the community's passage of the, I forget the Measure N, excuse me, Measure N, which allowed us to be able to get this advancing technology. Now, if only we get the state to allow us to use it, that would be great.
Yeah.
Okay, Rosie,
Right?
yes. At first meeting, I did a brief verbal report. I wanted to have a little bit more. And I think most of you have heard from me in individual conversations, but I thought it would be well to review a few of these financial performance key areas for us, a revenue cycle. And I know that Julie and Mike Russell are working on making some things happen that are going to directly impact. And I've asked them to try to be as specific as possible about changes and what the impact is being shown so that we can share those improvements with the board. The surgery services we're working on, we're still in the middle of the refresh on the ORs. Our lights are not coming in for several more weeks, maybe 10 weeks, is it now? I think, Steve? Maybe something around 10 weeks, so that's still in place. I have been having some success in getting some further engagement with some of the surgeons. We do have a couple new surgeons that are going to be coming on board. And so I think there's some positive work that's going with that. Service line growth, I'm referring largely to the surgery work, but also with our imaging. I think because of the advanced nature of this technology, I think if we do the right thing with sales, I think we can get some drive out of that particular service line. Okay. Well, I've already mentioned the MRI and CT. No, okay, just right here. Market development. With this, we have a few things planned. We do want to raise some community awareness. I think I'd like to get an open house where we have these facilities. And I'll probably offer each board member a free MRI. So you can see it's great technology and it's very impressive. And when we did have a media person from one of the local papers, they were very impressed with the technology. They got to see it up close. And it's a real benefit to the community for people, particularly that are claustrophobic. And I think the board all knows this, and we want the public to know about it too. Okay. We're working on central scheduling. It's part of our revenue process, but we've had some challenges with scheduling, and Mike and Julie have put a fair amount of effort into some staffing adjustments, some changes in how we do our work in that area. And the goal is to reduce what had been a backlog because of some of the processes we've had to employ in our scheduling. And I think as they have success, we'll see revenue improvements as well, as people are actually getting scheduled in to get their MRI or mammogram, whatever it might happen to be. Similarly, with the registration process, I gave them the go ahead to make some hiring decisions to supplement our staff. Sometimes when people call up sick or go on leave, we're ended up short-handed, and that creates a backlog, which is a big dissatisfier for our patients. So I think they're making some headway there. And I've also asked them to include in this, I think you're all familiar with AIDIT. It's a term that's where we acknowledge the patient. we introduce ourselves, we tell them how long what the duration is gonna be of what we're working with them on. Forget what E is, help me out.
Explain what's happening.
Explain what we're doing, and then the last is thanking. And there's a couple areas, particularly the areas that are closest to our public, our patients. We really need to reinforce those good qualities that we want our frontline people to have when they're working with our community. Okay, Rosie? Our emergency department has some new things happening. We've opened up a fast track unit. And we think that's going to significantly reduce the time that we tend to average for patients that are treated and then discharged. And I think right now we've seen some initial improvement, and Susan, help me out.
I think we have about a 20-minute reduction.
Yeah.
And we're also getting people out of the hallway, which looks
Nice.
bad for everybody, right?
Yeah. So, next step in that, I'd like to meet with Dr. Claypool and see if we can get the triage. We're not done in the waiting room. I don't like that look. It's not as private as I'd like to see it be for our patients. So I will be walking the ED with Dr. Claypool tomorrow to see where we can make some changes. And then have the waiting room be just the waiting room, not something that's cut in half. Primary care, I will be doing some more work with our foundation model. I'd like to see us have some more primary care docs in a strategy to give us more distribution across our service area. And I am going to be talking to Salute about how we might work together. I talked to Donnie Young about it, and I'd like to see if we can do some joint recruitment that they can help us with, and perhaps we can help them with. That'll get us more providers into our network and patients into our hospital. I think you all know that I've been working with our ad hoc committee on affiliations, and we have some things we're in the middle of that I'm guardedly optimistic might be something good for us. But we are working on 3 or 4 different approaches, and it's my hope that we'll be able to get one of these to work with us and help us long term. I've mentioned my thanks to the board for their work on advocacy. It is something that I will be getting involved with. I am serving on the HIP board, taking over for Steve, who is on that. It's a pretty lively group, I think. And I'm glad to be a part of that. I'm reaching out to leadership, anybody that'll talk to me. I did talk to the county administrator for Monterey County this morning. Tony had made that suggestion and helped get me introduced, and I'm going to be meeting with their leadership team to talk about areas where we might collaborate, particularly with their hospital in Monterey County and Natividad. There's a lot of commonality, I think, between what we do, where our focus has been, and what Natividad has. So we'll see if we can create more collaboration with them in the future. I don't have anything more to say on this particular slide. Thank you. And now that my voice is about gone, I think I'm done. Anybody have any questions for me? Have I left anything unattended that you would like me to speak to?
Any questions for Tim on his report or? Okay.
And Susan has a few items that I'd like her to add to my report. If you would, Susan.
Yeah, thank you, Tim. Primarily, I want to speak to kind of the status of our NICU and L&D units. As we talked about last meeting, we're planning to have 5 new people start this last new hire orientation, which actually began this week. 2 of those people did not weren't able to pass their credentialing items, so that was a blow because they were both L&D nurses on our night shift, which is where we're struggling. And then another person who was scheduled to start got into a car accident, unfortunately with her family, which is impacting her ability to work, so she was unable to start as well. So that leaves us with 1 hire on both shifts. It's not really the bench that we were trying to grow. That being said, we're not able to reopen a NICU at this time in a safe manner. I think safety is paramount to everybody. We do have a couple of travelers that are slated to start on September 21st, I believe it is. But before that time, I don't see any way around us being able to reopen at this time. And additionally, we had 11 people in total, 9 of whom were from the L&D and NICU groups who have tested positive for COVID. So we've got an outbreak within that. Few staff members that have self-disclosed that they are also COVID positive throughout the hospital, but it's primarily focused in that area. So again, NICU will remain closed. Labor will stay open. Tim and I are monitoring this daily to see if we have any further occurrences. And we're working closely with Michelle and Monica to make sure that we're doing our due diligence in terms of reporting to the county, getting their guidance that we're doing the right thing. What we have implemented in the meantime is a 2-week masking protocol that is mandatory in all clinical areas, patient-facing areas, to prevent hopefully any further spread. And that's primarily what I want to update you on.
Sure.
Are there any questions?
Thank you. I do. Our positions posted and are we recruiting for?
We are actively.
Do we have activity? Are people applying?
We have some traveler candidates that.
Sure. But anybody before September 21st?
Yeah.
It's at some point, I don't know how I know this. I thought what we were offering for travelers was quite low. I don't know how the traveler system works in terms of whether the company says, here's what we cost, or so. Is there any way to expedite getting people sooner than it's a month away?
We did go ahead and raise them. If I may jump in.
Pardon?
We did about a month or so ago, we did go ahead and we had gone back down to market and market went back up and we got the approval to go back up to market.
Okay, thank you.
Thanks, Margaret.
That's my question.
Anything else I can answer for you?
Any other questions for Susan? No. Thank you for the update. I was going to ask about this to Tim, so just thank you for the update on the NICU. And also just thank you for contacting the county, ensuring that we're doing the right thing, that we're following the correct procedures. And I understand that this is going to make it challenging for us to continue the labor and delivery services. So that's the reality, at least in the short time until this cluster of cases passes, right? That's the reality that we have to face that could potentially happen at the hospital over the next 2 weeks as we continue to test and hopefully test negative for COVID in the coming days. So yeah, just thank you. And these things happen in hospitals. I understand that. We're one of the few hospitals that disclose this in a very transparent way, as the way that we do all of for a vast majority of what's happening inside the hospital. And I, as a representative of the public, I appreciate the transparency from both Tim and from Susan on what's happening. Thank you.
I echo that as well. Thank you. I know that it's difficult. I appreciate the transparency.
Okay, if there's no other questions, Tim, I'll let you. Yeah, I don't know if we could do some shit over there, but
Yes.
just a couple of comments on your presentation. For licensing, just keep at it. We're gonna have those CT and MRI scanners open one day, and the public, I'll take the first MRI if no one else will take it.
Okay, you're on.
It's a lottery, and there's a fee for entering the lottery.
We have our wonderful Watsonville Community Hospital Foundation Executive Director in the house with us, and when you said open house, my mind immediately went to June of how we can welcome in our partners, but also members of the community as well, who their tax dollars are paying for this beautiful equipment that is nowhere else to be found on the Central Coast unless you go out to Sanford. And so I do want our community to, if they are interested in being wowed by an MRI or CT scanner, to be able to come in and see what their dollars are doing for our community and for this hospital. And really, we can't open them up soon enough. We didn't touch on it, but the emergency department, I appreciate you taking a look at the waiting room and the triage system that we have in place right now, where, you know, our waiting room is split in half. I think it does help folks move quicker. And at the same time, I know that it is a little bit of an eyesore. The public image of what we're showing our community as they walk into the waiting room. And I understand the reasons why, and so I just appreciate you having that conversation and seeing if we could find an alternative. So thank you for doing that.
I'll be working on that tomorrow with Dr. Claypool and probably Kristen as well.
Thank you so much. With Measure N, obviously, my hope is that, and the messaging will be great, is that these are the two big kind of public facing tools that we've been able to purchase with Measure N dollars, and to be able to communicate that we are actively looking at the second round of Measure N tranche dollars for 2027 for this board and for the hospital to continue to reinvest back in the hospital. And moving forward, the emergency room that project is really exciting at this time. So yeah, just thank you for your report. I think you're on day 50 something now, is that right?
52. 6 weeks.
6 weeks. And thanks for all your great work, and for the team for supporting Tim and what has been a really breakneck pace that you've brought to the hospital, to the team. So just thank you everyone for the work. If there's no other comments, I'll hand it over to Julie now for her report, and we'll move on to item number 6. Let's see, Chief Financial Officer of the Finance Report.
Almost, let me just share it.
Okay. So month of July, we did have a loss in the month of July of about 982,000. A few things that did happen are, you can see our net revenue is up, and primarily Clock 9 was approved. Doesn't mean any cash was coming in the door, but it was approved. So we start booking both the revenue and expense, and we will do so for the last 6 months of the year. That, you know, helps the net revenue. Had a little bit of offsetting entries with higher than normal bad debt and a decline in the payer mix during the month of July. Our labor and supplies, the other two, the two expenses with the largest variances, really most of it's volume related. We did have some one-time expense in the labor side, but most of it is volume related. And then the other is where we category other, this is rent and other, is where we recognize the expense of the QAP program. And there are dollars that are starting to go out in support of QAP 9, as well as the end of QAP 8. that are hitting us, but we spread those more evenly. Next slide. From a year-to-date basis, things look more favorable primarily because of the $10.6 million that we posted last month. So you can see we're $9.6 million of net income and $13 million ahead of budget. If you took out those one-time revenue recognition items, loan forgiveness, the large grant, we'd be about $300,000 off of budget, a little bit, 300,000 below budget. Next slide. Month-to-date volumes, as we've been seeing kind of all year, most of our volumes are exceeding budget. Wanted to kind of call out because there's been a lot of conversation lately. When we talk about patient days and we talk about the med-surg tele unit, over the period of the year, or over the period of July, we were averaged about 19 med-surg tele days, and we've got capacity for 30. And we would average about 6 admissions a day. Doesn't mean every day, but average. And then in the labor and delivery OBGYN area, we were averaging 5 a day with 2 admissions a day. I think most of the volumes were good in the deliveries, the surgery volumes, they were all decent. Slightly down in ER, but not a lot. And, the one area that's been hung up most of this year has been the non-outpatient ED. We had a little bit better volumes for the month, but we still got a year-to-date variance there. And just to point out on this slide, sorry, can you go to the next slide? On the year-to-date volumes, we're running just under year-to-date average daily census of 30, and we are pretty much at budget with our inpatient surgeries, and about 10% over on our outpatient surgeries on average, about 125 outpatient surgeries a month. About 5% up in the ER to budget. Next slide. This is just the volume trend that I show every month. Length of stay was lower this month. We saw most of the lower length of stay in the med-surg tele. It was a little bit offset in ICU. We had very low patient volume in ICU, but a few longer lengths of stay. Next slide. Deliveries was up this month, so we kind of hit 70 with 7 NICU admissions. Those NICU admissions, very low length of stay. And when I looked at the first 6 months of NICU admissions, 82% of those patients discharged home. So I think we had 7 that actually transferred to another facility, most likely Stanford. On the ER visits, we averaged 87 per day for the month. Remember the last couple months, our ERs to admissions were down. We kind of bounced back up to the ranges we were used to at 6.7%. Probably still low for a hospital, but a bounce back from where we've been. Next slide. Non-ER visits, we averaged 99 a day, a little bit of rebound, but we've still got stuff to make up. Next slide. The top volume surgical cases, the same as always with GI, general surgery, and OBGYN, and kind of the most significant increase being in the general surgery this month, going up by 9. Next slide. On the outpatient side, OBGYN, ortho, and general surgery kind of led the pack. Everything's pretty much normal ranges. And 24 robot assisted cases. So our robot does consistently getting used. Next slide. On the inpatient payer mix, down a little bit in commercial, down a couple percentage points, and that was really offset with Medicare volume. Everything else was pretty much right in the normal ranges. Next slide. On the non-ED, really not a lot of shift, a little bit between to the good for commercial, a little bit higher in commercial, and down in the managed Medi-Cal. Next slide. On the ED side, pretty consistent, really still sitting at about 50% of our patients coming through the Managed Medi-Cal Alliance. And, you know, we are sitting at about 4% that are coming in as self-pay, and that's been fairly consistent. These do still go through the referral process out to see if we can find eligibility. And so sometimes some of these will convert to eligibility. I'm going to talk a little bit later about some of the things that we are seeing as a result of HR 1 that we'll probably start to see more in some of these numbers. Okay. Leaving those kind of normal slides that I ran through pretty quickly, just want to give you some cash and AP updates. The AB 108 funds that we got in the middle of June, you know, we will have used those up by the end of this month, August. We were able to reduce our AP backlog by about 3 million, and the rest of it has kind of gone into covering our normal expenses and the fact that we run a shortfall of about, you know, $85,000 to $90,000 a day. You know, so roughly $2.5 million a month. And that's what we've been using to kind of get through the summer and awaiting the QAF 9. Next slide. Some of the additional cash that we've been, you know, looking for, the supplemental funding. So yes, QAF 9's finally approved. It was less than was modeled. What was modeled, it's about $2.6 million less than that. We net about $17.6 million in QAF 9. Basically two major funding time periods. One is October and one is April of 27. We are already starting to draw out of the October to help us, you know, kind of continue with operational needs. The QAF 10, which is not yet, it's been submitted to CMS, but not yet approved. You know, we don't get a lot of intel on when it may be approved. Most people at the legislative level say kind of best case end of the year. You know, I'm hopeful that it is approved by the end of the year and that they do try to expedite the distribution of funds. That kind of what they claim they're doing with QAF 9, but it's not super fast, and it does require upfront payments from us to get those funds. Although I do a lot of negotiation with the state on how we make those payments. The IGT that we've been waiting on now for a few months is still delayed, and so we don't know exactly when the CMS is going to say, okay, we will send out the invoices for you to pay your portion to turn around and collect the funds from the federal government and pay us back more. So that has been a bit problematic for us, and I just, you know, have to keep moving it forward in our forecast. I think the thing that's going to hit us more is this last bullet point. In QAF 9 and part of HR 1 is now the exclusion of unsatisfactory immigration status patients, and so that means that these patients are no longer eligible for the Managed Medi-Cal program through, you know, the Alliance. And some of them may be able to, you know, fall to just the Medi-Cal fee for service. That's a lower reimbursement for us. Some of them will just end up with no insurance. The interesting thing, and I've noted here, QAF 9, the fact that they pull out the encounters, and so the hospital industry averages compared to where we're at, we have more of these patients being pulled out than the industry average. We're about 2% higher on the inpatient non-OB, and I estimate that that's probably, you know, 100 days worth of you know, patient days. On the outpatient non-ER, it goes from hospital average of 14%, and we're close to 35%. So I estimate that could be, you know, 6,000 visits. This is going to hit us, and it's going to hit us from patients showing up in our emergency room without insurance or sicker because they've put off care as long as they could and they need to be here. So the Alliance advocated heavily before the state budget was, you know, signed by the governor to have this this exclusion carved, or this carve out, excluded from the budget. And it unfortunately wasn't successful so this is in our budget this year, or not in our budget. Next slide. Jumping to service lines, and I'm not gonna go through every line, I just kind of want to walk you through from the top level what I'm showing you, and I'll use the emergency department at the top as the example. Our emergency department in the first 6 months of the year, we've had 17,086 visits. That's an average of 94.5 days, patients per day. It's up about 1% over this time period last year. We have an estimated contribution margin, which is the kind of financial impact before you add on overhead and other support services. It's not just overhead, it's support services like dietary and EBS, things like that. So, but with that sort of a contribution margin, it says it has the potential to, with the number, estimating 35,000 visits a year, it has a good dollar impact. This is the 6-month dollar impact of about $7 million of positive contribution margin before overhead. And then I just showed the payer mix is about 76% government, 11% commercial, and whatever else you need here to add up to 100% is your self-pay, which we know in this case is about 4%. So I've done that for each of the major service lines, and just to point out a few things, you can see in ICU, women's and children's, and NICU, we've got some pretty significant declines year over year. So first 6 months of 26 versus 25, and those contribute, fairly heavily to some of the unfavorable contribution margin. And these are also some of the lower volume services. And you can see that we have some pretty high government payer mix in there that it does not reimburse as well as some of our commercial mix does. So I just kind of wanted to point those out to you and, give you a sense of what we've been looking at and trying to think about as we are challenged with many different financial issues. Next slide.
Julie, can I ask you a question?
Yeah.
You mentioned the impact on us with HR1. Are you able to give a rough translation of that into dollars? How much cash we would lose by the number of pages that we're expecting at the end of June now versus?
I was gonna go there, and then I realized I did not have enough information to do that. These things, I try to simplify it, but these things, there's consultants that actually kind of work in this space because it's not necessarily a simple thing, and there's still pieces of it that are missing. So, I'm hopeful that, over time, as our consultants work through the modeling, that we might be able to get there. Yeah. On the final slide, I just wanted to give you a heads up. It was time for our annual Moody's rating review. So we went through that process. The Moody's confirmed our BA2 general obligation bond rating. This is the same as what it was last year. It's got a stable outlook. It's been revised for some of their methodology changes. And then they also have a new rating called the issuer rating. We've got a B3 rating. And, primarily what they spoke to is that the reasons that our ratings sit where they are is because we have low days cash on hand, and we have still fairly volatile financial performance. They do take into account other things about, the community we serve in, some of our operational successes. They even see the success we've had in our 2026 financials being much better than our 25. And so this is our rating, and people that want more information is posted on Moody's with a lot more information about it. And with that, I'm here to answer questions.
Any questions for Julie? for her report.
So should, I just ask you to confirm, I had heard we got 18.7 with Quad 9. You, I mean, yeah, Quad 9, tonight said 17.6.
17.6, right, 17.6, I believe, is that, if that's the net between, you know, what you get and what you pay to get it.
I got it, thank you.
Any other questions for Julie about her report? I do have a couple of questions, Julie. For the IGT buy-in, I know that some partners also bought in with us. Have we now?
No partner buy-in on that.
Okay, and then if we can go back to the slide on the service lines, yeah, that one previous there. I think I was gonna have the same question that Tim had, which is, you know, this is the through 6 months for this year, and it's the good perspective is the volume change. I think that I keep looking at, or I was looking at when the slide was up, is the percentage for volume for those three being down across the board. I wonder if it's for the ICU in particular, just having it be down and the extended period that it was down earlier this year. Is that a big bulk of that 36%, or is this, you know, people not coming in and us not being able to activate the legal ones?
This is people not coming in, our actual admissions to the ICU, because we were down for a weekend when we had a staffing issue, but most of the time when we've had the unit closed, it's because there are no admissions to the ICU, and that's when we have staff on call in case, you know, an admission starts to bubble up in the ED. So this is truly that the volume is down.
Dr. Gallagher?
Sure, I just wanted to clarify, I heard both NICU and ICU, but ICU, my understanding is that the ICU census was capped at 4 at the beginning of the year. Steve, I have heard that from ICU nurses.
Yeah,
So I don't know how much that plays into it, but I think it is a factor.
we rarely hit an admission, 4 admissions in the ICU. And I think we may have had conversations about potentially capping it if we couldn't, you know, get the right staffing mix or things like that, but that wasn't a definitive action that was taken.
And then for the women's and children's on the volume change from last year to this year, how far away are we on the patient days from budget from where we're at right now? I think it was on an earlier slide, but we don't.
Yeah, you're talking about the women's and children, that's actually, I don't actually show the patient data.
Right.
What you see on my other side is the admission or the deliveries.
Deliveries.
Yeah, which, you know, we're 44 deliveries off, and most of those have an average census of about 2.5 days. That's usually what we see, 2 to 2.5. So, you know, that's, you know, gonna be 100 days or so.
Okay, understood. And I think similarly with the 7.2 million for the emergency department, that's before the overhead on those departments and additional costs. So I'm wondering what is like the true cost of ICU and the other ones as well. With then you factor in overhead and everything like that. I'm sure it's less favorable, but is trying to understand like less favorable by how much for all of these different departments, I guess, for the service lines. Does that make sense?
I think so, and I have those numbers, I just didn't want to have too many numbers on this slide, you know, kind of lose people in my concept because, so, you know, I could bring those back to another thing. I mean, the way we I try to allocate overhead is somewhat dependent on, you know, there's no perfect methodology, so you try to do kind of a usage-based thing, and so it's going to look, the amount of overhead that's allocated to ICU is going to look very different than the amount that's allocated to the emergency room.
Sure.
But, you know, in most of these cases, well, in all of these cases, it's going to be, you know, add more than $1 million or a couple $1 million of further decline to these numbers. So, you know, if you looked at the ICU and you double this for an annual loss of $5.5 million, you're probably looking at closer to 7 or 8 million by the time you layer on the overhead.
Understood. Um, thank you. Those were all my questions. Any other questions? Sure. Please.
One around the contract to get people on Medi-Cal for those that are uninsured. Because we know it's been fairly consistent and fairly low, because people have been on Medi-Cal. Do we anticipate having to like increase that or because of HR1 and knowing that that volume of uninsured will likely increase?
Yeah, that contract is, basically contingency based. They have to convert people then we pay them to convert people. Also, anybody who's indigent, whether they convert or not, they're gonna try to collect, self-pay, because they collect our self-pay and our even self-pay after insurance balances. And so they only get paid if they collect.
Gotcha.
Okay, any other questions? No. All right, thanks for the report, Julie, appreciate it. Move on to item number 7. This is the Community Access through Responsible Evolution Ad Hoc Committee report out. This is the CARE Ad Hoc Committee comprised of Directors Pimentel and Gallagher. And our interim CEO will also aid in the presentation. So Director Gallagher or Tim, whoever wants to take it.
Dr. Pimentel encapsulated into the report. We have had weekly or every 10-day meetings looking at service line and costs and analyses with the idea that that information is put in as good a shape as it can to our September special meetings. That would be the short version.
I don't really have anything to add to that.
Okay. So you mentioned of the September special meetings. I've been working with Tim to schedule some, as we did last year and as we have traditionally, some leadership retreats and some strategy sessions for the board to hear where we're at financially, and also what is happening around us and what is going to happen to us in the same way that we did last year, and hopefully come up with some solutions in a path forward. And so as it stands right now, we have on top of our regularly scheduled board meeting for the last Wednesday of September, we also have 2 special board meetings that we're working to schedule in September, where we'll bring the work of the CARES committee for the report out on service lines and potential growth initiatives for discussion and continue the discussion that I was hoping would start here into September. So anything else, Tim, I think with this?
Maybe might want to comment on conversations with stakeholders, people that we would like to see participate or come to the retreats. We're looking for stakeholders that we work with.
Yeah, I think sort of like we did last year for, and I apologize for hijacking the report out. Please go ahead. Sort of in the same way that we did last year, where we met shortly after the approval of HR1 in August to think a strategy and how we were going to respond as a healthcare district and as a hospital to HR1. We brought some other folks around to the table as panelists so that we can inform our decisions and also get feedback from folks that are part of our foundation and also that speak well about the trends that we're seeing in healthcare. And right now we're trying to secure some panelists from the associations of healthcare districts so that the full board, along with our community, can understand what's happening to hospitals and healthcare districts that are similar to us, similar in size and similar in the communities in which they serve, and and have similarities in the challenges of which we're facing right now. Even before the bulk of HR1 is going to really hit us. A couple of the other folks that I have been working on bringing to these strategy sessions has been a representative of the County of Santa Cruz for the Health Services Agency. I would like for them to be able to be there with us and be a panelist with us to give us an overview of what's happening throughout the County of Santa Cruz. Their strategy that they're employing, what they're seeing with their health services, and can possibly talk about Measure E and what their strategy is behind Measure E to potentially have some additional revenue generated heading into the middle of next year that could potentially defray some of the costs of HR1, of the impacts of HR1. And we've also are working on getting someone that can speak to the changes from HR1 into exactly what we've been talking about earlier, which is the changes to Medi-Cal, how that's going to impact healthcare providers, how that's going to impact federally qualified health clinics, and obviously how that'll impact us, hospitals, and what that'll mean for our revenue for next year. And so the hope is that we have 2 strategy sessions. We're able to meet with other partners as well independently and get an understanding of what's happening to healthcare providers throughout our community and throughout the state. And as a board, really chart a path forward. And I think Julie put it really well in her report that our, as it's called in healthcare industry, our burn rate right now is about $85,000 a day. So that's we're losing about $85,000 a day as we're currently operating, and that at the end of the month is multiple millions of dollars. And so we know that we don't know the exact amount and the exact number that HR1 is going to hit us and is going to make it more challenging for us, but we do know it will make it more challenging for us. And so a good time and makes sense for us to come together with leadership and with partners to chart a path forward. So again, apologies for hijacking the report.
Mine, that's where you started. I didn't feel hijacked.
Yeah. And so, yes, Joe, maybe, or Director Gallagher, maybe you can talk to some of the work and how challenging it's been. I can add some color as well for the CARES committee of when we were first formed, what we were first doing, and then having to kind of shift and pivot over the last 6 or 4 months.
4 or 5 pivots. Initially, we were looking at an immediate cash situation prior to the Laird money, and Mark Pimentel and I put together a presentation to go to the county to ask them to guarantee a rise in the line of credit to get us some initial cash. Next pivot, these are probably going to be out of order or imprecise. There have been several. Steve Gray's announcement of his departure. Where did we go there? What were we looking at in terms of an interim CEO, et cetera, et cetera, et cetera. And so the mission and the focus has changed, and most recently on the specifics of service line finances. That's a sort of reductionist view. Marcus is much better at the precise detail. I'm a bit of a lumper.
Right. Just to kind of complement that, it's been a moving target in terms of the goals of the CARES committee. Initially, as Director Gallagher said, we had a plan to bring an overview of the hospital service lines, have a discussion around that, and as a board with our partners, with our leadership, and with trends, have discussions about our service lines, have discussions about our immediate future, and then what 2027 could look like as we head into our budgeting process. And the hope is that, which plan is, I should say, is that as we head into the September strategy sessions, that we're able to review some of that data, have some conversations as a board as to what the immediate future looks like, and then what the long-term future looks like for the services that we provide at the hospital. There's multiple ifs over the next few months. We talked about FOB 10, we talked about FOB 9, just mentioned Measure E. There's a distressed hospital loan program round 2 or grant program round 2 that comes, fingers crossed, in October, November for hospitals like us. And those are a lot of ifs, and good for us to understand what we can actually bank on and say that we will have access to this cash, and then to make decisions accordingly. Any other questions for Director Gallagher on the work of the ad hoc committee? Okay, and we will work as a board to get the dates out for those 2 strategy sessions, because they will be publicly notified, and open meetings that are open to the public for public comment, and work on getting those agendas out as soon as possible. Okay. So we'll move on to item number 8. This is the Chief Executive Officer recruitment ad hoc committee update. And the contact here is Emily Valley, Director Emily Valley, Recruitment Ad hoc Committee Chair.
Thank you. So, as I mentioned last month, we're going to go through each part of the timeline, and as we go through it, and talking about next steps moving forward based on where we're at. So if you go to the next slide, it's going to go over this. I remember this from last month. This was kind of our guiding principles of how we're going about the recruitment, and deciding eventually who we'll find. It's basically definitely someone who will reflect the district's mission, vision, values, and our long-term strategic needs. You're guided by stakeholder input. The Alex and Emily Roadshow has finished officially. And what you see tonight is kind of the analysis of all the feedback that we captured. So the next slide, please. So the search timeline, we revised this a little bit based on the work that's been done so far. So as you can see in the red, the first part of the timeline, we did the stakeholder meetings and synthesized the data from the surveys. We have actually, the job posting has been posted, kind of an initial piece. We are still working kind of on the flyer brochure to put out, and we're hoping that that'll be done within the next week or so. As we do active sourcing, which is basically reaching out to potential candidates or people that know potential candidates. And so, like I said, that will be done, that brochure flyer will be done within the next week or so. We've begun work on the panel questions and pre-screening information, and actively pre-screening applications as they come in, and we've received almost 60 so far. And so we're definitely going through that process. The next process will be, so we'll be doing this piece from now to the middle of September. Then we'll be doing from middle of September through October, doing the first round of panel interviews. And we're looking at, currently we're looking at 4 panels is where we're landing. And those will be with both internal and external stakeholders to participate on those panels. And then the final round of interviews will be with the board. And so next month, I'll adjust this based on where we're at that point. Next slide. So what does stakeholders need from the next CEO? We aligned what the feedback to what we put out in the recruitment initially and what we're putting in this brochure, moving forward. So next slide. So there was some clear messaging that we heard consistently throughout all the meetings and the survey feedback. We're looking for a visible turnaround leader who can stabilize performance while rebuilding trust. So the three words that kind of came out of this, the three were lead, connect, and transform. And when we talk about lead, it's really making difficult financial, operational, and accountability decisions. We've heard that word a lot. Accountability and someone who will make decisions moving forward and understanding the situation we're currently in. Connect is a lot about trust with both employees, physicians, partners, and the community. For that. And transform. This is creating a vision and a sustainable model for services, workforce, and long-term viability. That forward thinking. So basically, it's someone who can manage the current realities while also looking at the future. Okay. So, do you want to talk about that?
Yeah, I can talk about that. So we took both the recruitment profile that has been public before, and we put it together with the stakeholders' priorities to ensure that it matched or to make adjustments if it didn't match what our stakeholders were asking for. The beauty of it was it actually did align with what we believed that the recruitment profile should include, and it added specificity. I'm not going to read every single one, but you can see here for the first example, the visible and approachable. What does that actually look like in practice? Rounding, staff access, and a community presence. And some of these looked very different when it came to just the in practice, because you can put things in a recruitment profile, but having the understanding of what stakeholders really needed and wanted, that's where we really will be looking in and diving deep.
And I think all these matters, we go back and look at that lead, transform, and they're all consistent. So.
Next slide.
Next slide, sorry.
I'll check that.
Yeah.
So these were 6 priorities that came out of the feedback that really we're going to look at as we're identifying candidates and screening candidates. And for example, first is someone with financial and who can lead a financial and operational turnaround, stabilize cash flow operations, contracts, and performance. So there's a lot about stabilizing in that accountability piece that was mentioned in the first slide that I was showing. Physician partnership and accountability, build trust while enforcing clear standards. Workforce stability, improve morale, retention, communication, and leadership consistency. I think some of you that participated in these, there was a question around what should the next CEO focus on, workforce, retention, morale, and the consistent answer we got was all of the above. So all of the above are on here for under workforce stability. Someone who can look at the service line strategy, which is balancing community needs, quality, staffing, and viability. And community credibility, someone that is visible, culturally responsive, and transparent. We heard loud and clear, someone who wants to be in this community and participate within this community and is willing to be visible and out there, both internally and externally. And the last piece was someone who can develop strategic partnerships, which is developing networks, relationships into clinical and financial value. Really what this means is someone who can reach out and network within the community, within the district, to look at the healthcare system versus just within the walls of the hospital, and develop that and look at what Watsonville's hospital's role is within that healthcare system in this community.
Sure. So one thing that we do note is when we look back, you'll see that there are some contradictory terms there. When you're looking at community access, that means that to many people is creating more. Well, we don't have more because we need financial discipline. And so the strongest candidate will be able to manage the four tensions, either knowing which direction to go in the beginning and clearly explain that, and then explain when they'll be able to expand, or being able to walk that tightrope as a leader does. Accountability and collaboration. Sometimes holding people accountable does not always look like collaboration or feel like collaboration, but we need both of those things. And listening and decisive action. When you have to make a decisive action, even if you're listening, sometimes people also don't feel good about that decisive action that's made because it's not what they want. And then really, I think one of the clear pieces is the immediate stabilization mixed with the long-term strategy. What's your vision? You might not get to that place yet, but what do you plan to do if we can get to this immediate stabilization first? So you really want them to be able to walk that fine line and see both, and that's hard. Next one, yes. Sure.
So as we captured all the data, weighted kind of all this feedback into kind of where things landed. And so obviously first and foremost was the financial and operational leadership was number one. Strategic execution turnaround, someone that can develop those strategies, physician relations and accountability, and workforce culture and retention kind of rose to the top. All of these were things that came about that were important, but it really those four areas really did rise to the top and drew out all the feedback in there.
So based on this is the recommendation for the board carrying into the selection. So our panels and our final interviews will reflect looking for evidence of measurable hospital performance improvement. So looking for tangible understanding of that and what they've done to improve hospitals. Test whether collaboration includes the courage to hold people accountable. That's a really big piece that came through to us. Looking at ensuring the concrete leadership practices are in place. It's not just a personality trait. It really is reflected in their leadership style. And then another big piece we actually didn't touch on earlier was the cultural competence. So that's very important to our community, and people need to understand the people that walk through our doors and the community that we live in. And hopefully they would have that experience in communities like Watsonville, and that is something we are actively looking for. And then the leadership structure and board support, the next CEO needs to be certain they can understand how to work with the board, work with the foundation, work with all of the different pieces that are go into this type of a hospital. Okay, next.
Yes. So as I mentioned in the timeline, this is a lot of what's in that first is that the job has been posted and the flyers being developed. We're putting together the screening rubric so that we're evaluating applicants consistently. That we're developing the questions that really align with the stakeholder feedback to get at this information that's all in this presentation so that they reflect that we can get that information from the candidates. And a rubric will be developed for that as well. Again, just wanting to be consistent as we're throughout this whole process. The first round of interviews, we're going to start scheduling those in late September. We'll look, again, this timeline is just based on what we're thinking right now, depending on the candidate pool. And we're going to develop the panels with internal and external stakeholders. And then again, the final piece will be the final interview for the role. I think that is it. But so basically what we heard in loud and clear was that people want this hospital to succeed. That was first and foremost what everybody wanted. And we want a CEO for this hospital, not just someone who's wanting to be a hospital CEO, someone who wants to be in this community, engage with the community, both internal community and external community, moving forward. And now our job is to make sure that the rest of this process is to get the person that will be able to do that successfully for this hospital.
Any questions, from the board or the ad hoc committee? I do have, just some comments, just first off, just incredible amount of work that the two of you are doing. Just the wrangling of cats to get in front of them. And everybody's busy and it seems like there's a crisis wherever you turn over. And so people are choosing to be a part of this process and to give you the feedback and to take the time to be attentive and to give you honest and I imagine in a lot of instances, very forthcoming feedback, right? And this is great. If we can go back a couple slides, Rosie, that one right there, it's kind of it's no mystery to me that financial operational leadership are at the top, really. I think for everything that we have been able to accomplish in the last 4 years, as a board, as a hospital, as a team, what we have not been able to do is that, right? Is to find financial stability. And so it does not surprise me at all that through all of these interviews, people internally, externally, what they want to see is a hospital be financially stable and to be an excellent provider of care. We've got one part of that. We got to get the other part now. So again, just some comments. A ton of work. Thank you for all the work. Thank you for the two of you stepping up. And for my money, I think that both of you are well qualified to do this work. And I'm happy that you guys are doing it. So with that, if there's no other questions or comments or anything else from the ad hoc.
And just thank you to everybody who participated in this process and trusting us, being very candid and forthright with their input. I truly enjoyed this process. Yeah.
Are enjoying.
I enjoyed it.
Yeah.
That part was really good to meet everybody. And we really talked about that. This is the network for the next CEO, especially the external candidates, the internal stakeholders. It's really everybody that, like, here's your people, here's your tribe that you'll be working. So.
Okay, so with that, that brings us to the end of the hospital board of the hospital board meeting.